In our last video, we took you through the fascinating history of all-on-4 dental implants. We talked about how the original concept revolutionized dentistry by giving patients a full set of fixed teeth in just one day. But we also talked about the flaws, the acrylic prosthetics that chip and harbored bacteria, the chewing restrictions, the significant bone reduction, and perhaps the biggest limitation of all, the fact that every implant was placed in the front of the jaw, leaving the back teeth hanging off the end with no support. Essentially, an unsupported overhang. Now, many of you asked the obvious question, and I appreciate the feedback. So what are the modern solutions? What actually has changed? And that's exactly what we're covering today. I'm going to walk you through 3 advanced implant techniques that have fundamentally changed what's possible in full arch dentistry. These aren't experimental. These are proven, research-backed innovations that we use regularly in our practice. So to set the stage, let's quickly recap the core challenge. Your upper jaw has this large air-filled cavity called the maxillary sinus. It sits right above where your back teeth used to be. When you lose these teeth, the bone underneath the sinus starts to shrink, and it shrinks fast. This is why the original all-on-4 placed all 4 implants in the front of the jaw. That's where the bone was most reliable. Problem is that your prosthetic teeth still need to extend to the back of your mouth so you can actually chew. Those back teeth were essentially hanging off the last implant with no support underneath them. We call that a cantilever, and cantilevers create stress, and over time, these stresses can lead to complications. So the question the entire field was trying to answer was, how do we get implants in the back of the jaw without going through the sinus? There are 3 brilliant answers. The first innovation is a pterygoid implant. Now this might sound intimidating, but let's break it down. Behind your maxillary sinus, deep in the back of your skull, there's an incredibly dense bone called the pterygoid plate. It is part of the sphenoid bone, one of the strongest, most robust bones in your entire skull. And here's what's remarkable. It doesn't shrink over time the way your jawbone does. It stays dense and solid regardless of whether you had teeth or not. So the idea was, instead of trying to go through the sinus, what if we go around it? What if we angle a longer implant behind the sinus entirely and anchor it into this rock solid pterygoid bone? And that's exactly what a pterygoid implant does. It's a longer implant, usually 18 to 25 millimeters, and it's angled backward at about a 35-degree angle, entering through the back of your upper jaw and anchoring into the pterygoid plate behind the sinus. You now have a true anchor point at the very back of your arch. No more cantilever, no more unsupported overhang. Your back teeth now have an implant directly underneath them, providing real support. And here's the best part. Because the pterygoid bone is so dense, we get incredible initial stability. That means that we can load it immediately, and you get to walk out with fixed teeth in the same day. Now, this technique has been around since 1989. It has over 35 years of clinical history. Studies show survival rates between 92 and 97%, and it's been formally endorsed by the American College of Prosthodontists as a validated and predictable treatment option. So this isn't experimental. So why doesn't every dentist offer it? Honestly, it's one of the most technically demanding procedures in implant dentistry. The anatomy is complex, the surgical access is challenging, and it requires a very deep understanding of structures involved. The learning curve is steep, and very few dentists invest the time to master it. The second technique takes a completely different approach to the same problem. Instead of going around the sinus, what if we go through it? That's the concept behind a trans-sinus implant. And yes, the implant literally passes through the sinus cavity. But before you cringe, let me explain why this is actually brilliant. The idea is that on the other side of the sinus, there's another wall of dense bone, the lateral nasal wall. It's strong, it's cortical, and it provides excellent anchorage. So we place a long implant that enters through the top of the ridge, passes through the sinus, and anchors into the nasal wall bone on the other side. What makes this technique so effective is something that we call 3-cortex fixation. The implant engages bone at 3 separate points: the ridge, where it enters, the sinus wall, and the nasal wall, where it anchors. Think of it like bolting through a wall. You just don't sit on the drywall, go all the way through to the stud and onto the other side. And that's what gives it such incredible stability. The research on this is very promising. 2024 systematic review found a 97.2% survival rate with no significant difference compared to a conventional implant. And because the stability comes from cortical bone engagement, we can load these implants immediately, same day teeth. Now, some of you may have heard of zygomatic implants. Those are very long implants that anchor into the cheekbone. Trans-sinus implants serve a similar purpose, but are significantly less invasive. The implants are shorter, the surgery is less extensive, and critically, they preserve your future treatment options. Zygomatic implants are sometimes described as a terminal procedure. Once they're in, your options become limited. Trans-sinus implants don't carry that same limitation. The third technique addresses a different problem. It's not about the sinus, it's about what happens when the jaw ridge itself becomes too narrow. When you lose teeth in the upper jaw, the bone doesn't shrink evenly. It resorbs primarily from the cheek side inward. So over time, the ridge gets thinner and thinner from the outside. But here's the key insight. The palatal bone, the bone on the roof of your mouth, is the last to go. It's denser, thicker, and significantly more resistant to change. In a conventional approach, when the ridge is too narrow, the solution was large bone graft. Sometimes we'd even take bone from the hip or the chin, graft into the ridge, wait 4 to 9 months for it to heal, and then place the implant. That's a lot of surgery, a lot of time, it's a lot of discomfort. The palatal approach flips the script. Instead of entering the implant from the top of the narrow ridge where there's not enough bone, we enter from the side where there is a lot of bone on the roof of the mouth. The implant engages that thick, dense palatal-cortical bone, which gives us an excellent primary stability. Any minor bone deficiency on the outside can be addressed with a small amount of graft at the same time. No second surgery, no months of waiting. The clinical data supports this approach strongly. Studies show a 96.9% survival rate at 5+ years, average bone loss of less than 1 millimeter. And here's something remarkable. 0 cases of peri-implantitis were observed in the published studies. That's exceptional. What this means for patients is that people who were previously told they were not candidates for implants because of bone loss, many of them actually are candidates. We just need to approach it differently. Now, these 3 techniques solve the foundational problem, where and how we place implants. But there's a 4th piece of the puzzle that's equally important: what goes on top. If you watched part 1, you'll remember that the original All-on-4 used acrylic prosthetics, the same material used in dentures. And for a fixed prosthetic that's bearing full bite force for every single day, acrylic simply wasn't up to the task. It's porous, meaning bacteria can get trapped on the surface. It wears down, teeth pop off, and over time, it can contribute to the bone loss around the implants themselves. Zirconia has changed everything. It's a monolithic ceramic milled from a single solid block. It is dramatically stronger than acrylic. It doesn't harbor bacteria because the surface is so dense and smooth that there's nothing for bacteria to cling to. It doesn't wear down. It doesn't chip the way acrylic does. And aesthetically, it's in a completely different league. The translucency and color are far more natural. At Smile Now, we've made the decision to stop using acrylic for permanent fixed prosthetics entirely. We use it for short-term temporaries, and that's perfectly fine for a few months. But for the prosthetic that's going to be in your mouth for 20 to the next 30 years, it has to be zirconia. The long-term outcomes are simply incomparable. Think of it this way. The implant techniques get you the foundation. Zirconia gives you the smile that lasts. So here's what I want you to take away from this video. Full arch implant dentistry has evolved dramatically from the original All-on-4 concept. We now have pterygoid implants to anchor to the back of the arch, trans-sinus implants to reach through the sinus to solid bone, palatal approach implants to work with the bone your body has preserved, and zirconia to give you a prosthetic that's built to last for decades. At Smile Now, we don't do cookie cutter dentistry. Every single patient gets a comprehensive evaluation, a 3D scan, thorough assessment of their bone anatomy, and we design a plan that's specific to them. Some patients get pterygoid implants on one side and a trans-sinus implant on the other. Some get a palatal approach combined with conventional implants. The techniques are mixed and matched based on what your anatomy needs, not a one-size-fits-all protocol. We have our prosthetic team and lab in-house, which means we can fabricate your teeth in the same day as surgery, and every permanent prosthetic we deliver is zirconia. The evolution from the original All-on-4 to what we do today means one critical thing: more patients are candidates than ever before, better outcomes, longer lasting results, and a much more conservative approach to surgery. If you've been told you're not a candidate for dental implants because of bone loss, I'd encourage you to get a second opinion. The field has changed. The techniques exist today that simply weren't available or widely practiced even 5 years ago. We offer a free consultation with a complimentary 3D x-ray scan. The link is in the description below. If you found this video helpful, please hit that like button, subscribe if you haven't already, and drop a comment telling me what topics you'd like us to cover next. If you haven't seen part 1, I'll link it right here. It gives you the full history of how we got to where we are today. Thanks for watching, and I'll see you in the next one.